Hi, this is Brian Kim. I'm going to share with you case number 206 in the best way to do cataract surgery series. This is a dense cataract, and you're going to see lens disassembly using double chop, cross chop mechanical fracturing techniques. But then this is an important point. As I'm implanting the lens, I notice that the haptic is broken. And so it's an important concept. Being able to recognize early and being continually aware and surveying and looking at the case from beginning to end, looking at the eye, making sure everything is perfect, because you just never know when things can go sideways. And so this is really the main point of this particular video. So I use a corneal marker, which will help me to center and size the rexus. And this is my paracentesis incision, first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine and then some intracameral dispersive viscoelastic to coat the corneal endothelium and flatten the anterior capsule. And this is the Triplanarconial Incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and then when I'm ready, I enter. And this is the microforceps, the Morio microforceps. I puncture the center. These have sharp tips. Pull down towards me. And because it has a sharp tip, you can use it like a cystotome, which can control the flap and the tear, grabbing the right side of the tear. And because of the thin profile, the chance of OVD egress is much lower. And so you have much more control for the rexus. Going around circumferentially, grabbing and re-grabbing. And you can see the teeth open quite nicely. You can grab, without much difficulty, the flap. I like to grab, every couple of clock hours or so. Finish off the rexus, burp some viscoelastic out. And this is the capsule fornix hydrodissection technique. I place a cannula under the rexus edge, contra-incisionally, point the tip down, get a nice wave. Go ahead and lift the lens up just a little bit, decompressing the bag, pushing down on the lens to decompress some more, sweeping on the left side and then the right side, and the lens begins to spin. Again, this is a fairly dense lens. Keep that in mind. Irrigating the surface of the eye, adjusting the sleeve, lifting the incision with the chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. This is a rather dense lens, so I'm going to go bevel up. I'm switch to dense mode, and I'm going to sculpt. Sculpting a central trough allows you to debulk the dense central core. But the good news is, with this technique using terminal chop, you don't have to go all the way down to the posterior capsule, which will, of course, expose the posterior capsule to the phaco needle, which is going to be a high risk for rupture. And so you don't have to go that far deep. You can go probably 60–70%, which is perfectly fine, because you will have debulked that dense central core. I'm rotating the lens 180 degrees apart and sculpting some more. And then I'm going to place a chopper around the rexus edge contra-incisionally. By placing the chopper out to the equator, I'm able to fracture from the peripheral edge. And by propagating it along the peripheral edge, I'm also getting and fracturing the posterior lamellar fibers, because remember, the posterior lamellar fibers are oriented concentrically. And so by fracturing the terminal edge, you're actually fracturing and propagating that crack through the posterior aspect of the lens, closest to the posterior capsule, and therefore you're able to avoid the posterior plate phenomenon. Placing the chopper around the right heminucleus and fracturing the lens completely in half, pulling the chopper centrally toward the phaco tip and fracturing the lens against the phaco tip, like the phaco tip is a chopping block. Using mechanical fracturing forces to crush the lens into smaller and smaller pieces, and then using sparing amounts of ultrasonic energy and vacuum to remove the lens pieces. As I've said many times in my videos, sparing amounts of ultrasonic energy is very important to reduce ultrasonic energy damage to the corneal endothelium. But another important point, which is understated oftentimes, is using sparing amounts of vacuum also reduces the chances of removal of the viscoelastic that's coating the corneal endothelium. And so remember that. You can't really see that viscoelastic, and so you don't really appreciate the fact that the viscoelastic is either there or not there. But if you use a lot of vacuum throughout the case and you have your port fairly shallow towards the cornea, you're probably removing the viscoelastic that's coating the cornea, and therefore you're going to expose the cornea to more damage. And so by using sparing amounts of ultrasonic energy and vacuum, by using sparing amounts of vacuum, you're not going to expose the OVD to the phaco tip, and therefore less likely to remove that OVD that's coating the corneal endothelium, and therefore better protection of the corneal endothelium with these techniques. Manipulating that last piece of the second quadrant, placing the chopper around the lens, hooking the peripheral lens, and crushing it in half, again with another cross-chop maneuver, using some vacuum to grab that piece, and then getting the chopper around it, and then fracturing the lens between the instruments, and then emulsifying the lens piece, using, again, sparing amounts of ultrasonic energy and vacuum. Grabbing that piece again with some vacuum. Again, you can see I'm in bevel down mode, and I'm always grabbing the pieces fairly deep at iris plane or under iris plane. Again, hooking the peripheral lens with the chopper. The chopping maneuvers and the disassembly maneuvers, you notice with the overlay, I never use ultrasonic energy or vacuum when I'm actually fracturing the lens. So I'm turning the second heminucleus in front of me, and again, I'm not going to use any vacuum or ultrasonic energy, just positioning the instruments around the lens, placing the chopper around the lens, and then fracturing the lens between the instruments. So again, positioning it again. The lens is turning on me, so I'm going to go ahead and try to grab it with some vacuum, positioning it, getting around it now. Again, getting around the lens here because it's turning on me. And then now, without vacuum or ultrasonic energy, I fracture the lens. Getting under the lens with the chopper and then crushing it in half. Again, that's a scissoring chop maneuver there. You can see the pieces are rather dense and they're kind of jigsawed together. And so you don't have to struggle. I'm turning the chopper sideways, and that's a scissoring chop maneuver, getting to the posterior adhesion and amputating the posterior adhesion with the instruments by turning the chopper sideways. This is a much more safe way to amputate those posterior adhesions. Again, I'm doing the same maneuver one more time there, placing the chopper underneath the lens and then rotating the chopper sideways. So I'm essentially being able to amputate the posterior adhesion, being able to visualize the chopper as it's cutting the lens. More importantly, I'm keeping the chopper away from the posterior capsule. So again, rather dense lens and rather stubborn. It's not trying to come apart. It doesn't just fracture and come apart. The pieces want to stay together, which is a characteristic of some lenses. Again, placing the chopper around that last piece, crushing the lens in half, and then using some vacuum to hold the lens, getting around the lens one more time, fracturing the lens again in multiple pieces, performing scissoring chop maneuver to amputate the posterior adhesions, protecting the posterior capsule, keeping that chopper deep. That's that final fragment there. Crushing the lens between the instruments, pulsing ultrasonic energy and vacuum, and keeping that chopper deep to protect the posterior capsule. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I always start sub-incisionally, trying to peel the cortex from anterior to posterior. By doing it this way, you get the cleanest removal of the cortex. Switch to polish mode, polishing underneath the rhexis edge of lens epithelial cells, polishing the posterior capsule as well, pulsing BSS into the subincisional capsule fornix, which was clean here. Turning off irrigation and then pushing cohesive viscoelastic to fill the capsular bag. Widening the incision. The pupil is a little bit on the small side, so I went ahead and just bypassed the sweeping here. Wiggling and getting the injector into the eye, but as I advance the lens, look what happens. You can see that there's two pieces. As I was advancing that leading haptic, I saw there's another blue thing kind of perpendicular to the haptic there, and that's because that haptic has been amputated. And so if I put the lens in the eye, I have to take it back out. That would be really bad for the patient, more surgical trauma, and more importantly, unnecessary surgical trauma for the patient. So I recognized that it was going on. I took it out. My surgical technician gave me a new lens. Go ahead and put the injector into the eye, fill the bag with more cohesive viscoelastic. The leading haptic is going into the bag now. Make sure I rotate the barrel so that the optic comes out flat, and then using a Maltzman to dial the trailing haptic into the bag. And so that's really the point here. Go in with irrigation off, activate irrigation, getting underneath the lens, removing all the viscoelastic from within the bag, removing the viscoelastic from underneath the anterior capsule with polish mode, removing all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, in this case, it's very important, like all cases, to pay attention at every point of the case. It's very important that you have your undivided attention when you're doing the surgery, and you need to pay attention to everything that's going on. And when you're not paying attention, that's when things can happen. So in this case, I noticed that I saw two blue little lines in the injector. And so as I advanced the lens, I saw one of the blue lines wasn't moving, which meant that the haptic was broken or amputated off. If I didn't pay attention and I delivered the lens, I would notice that the haptic was broken, and then I'd have to get microforceps and scissors, cut it out, and you just never know. Bad things can happen in those situations. I could have broken the posterior capsule, or something bad could have happened. And so really the key is recognizing early on and preventing a problem from happening, purely being focused and having a high level of acuity, attention to detail, and just making sure everything goes smoothly. And so that's really the main point of this case. Anytime you're doing surgery, if you want to do it the best way, making sure you understand and see everything going on at every step of the case, making sure everything goes smoothly. And by having that heightened awareness and that desire to do the very best, you'll be able to execute your best with every surgery. So I hope this was helpful to you, and I thank you for your attention.